Metformin is widely prescribed and generally safe, but long-term use is associated with 4 clinically important side effects. In this video, I'll explain what these side effects are, how and when they develop, who is at risk, and pharmacists' tips to prevent or manage these side effects in clinical practice. Let's start with the most common one, gastrointestinal side effects, and understand how, why, and in whom they occur. Gastrointestinal adverse reactions are the most commonly reported side effects of metformin. These are usually transient or reversible and can include diarrhea, nausea, vomiting, flatulence, dyspepsia, and abdominal pain. To understand why these effects occur, it is important to look at the proposed mechanism behind. Gastrointestinal side effects are dose-related. Although the exact mechanism is not fully understood, multiple mechanisms have been proposed that may contribute, including 1. Alterations in intestinal transporters, for example, OCT1 transporter. Metformin uses intestinal transporters such as OCT1 to enter gut cells, and changes in these transporters can cause higher intestinal drug levels, irritating the intestine and leading to nausea or diarrhea. 2. Serotonergic-like effects of metformin on gut motility. Metformin can act in a serotonin-like way in the gut, speeding up intestinal movement, which reduces absorption time and results in diarrhea and abdominal cramping. 3. Direct or indirect increases in GLP-1 levels, which helps blood sugar control but can also slow stomach emptying and cause nausea or fullness, especially when treatment is started. And last proposed mechanism of metformin causes gastrointestinal side effects is disruptions in bile acid metabolism in the intestine, which can contribute to loose stools and other gastrointestinal symptoms. The timing of gastrointestinal side effects can vary depending on the individual and the therapy regimen. These side effects typically appear shortly after initiation of therapy, although late-onset diarrhea has also been reported. Certain risk factors can increase the likelihood of experiencing gastrointestinal side effects with metformin. These risk factors include rapid dose escalation, use of immediate-release formulations, chronic asymptomatic gastritis, H. pylori infection, and concomitant use of OCT1 inhibiting drugs, for example verapamil. While GI side effects are common and usually manageable, metformin can also rarely affect the liver. Let's look at hepatotoxicity next. Metformin-associated hepatotoxicity is rare and mostly reported in case studies. It can present in different patterns: cholestatic, which is elevated bilirubin and alkaline phosphatase, hepatocellular, which is elevated alanine aminotransferase, and mixed pattern, a combination of cholestatic and hepatocellular pattern. Importantly, hepatotoxicity generally resolves after discontinuation of metformin. Metformin-induced hepatotoxicity mechanism is not dose-related and it is considered idiosyncratic. This means it arises unpredictably and is likely due to individual susceptibility rather than the amount of drug administered. The timing of onset of hepatotoxicity varies widely, making it important to monitor liver function throughout therapy. Reported cases show onset anywhere from 4 days to 8 weeks after starting therapy, although latency periods of up to 10 years have been described. Certain patient characteristics and concomitant exposures can increase the risk of hepatotoxicity. For example, concurrent use of metformin with other hepatotoxic drugs or substances, age greater than 50 years, and male sex. Another rare but serious side effect is metformin-associated lactic acidosis, MALA, which requires careful monitoring due to its potential severity. Symptoms are often nonspecific, including malaise, myalgia, respiratory distress, somnolence, and abdominal pain. MALA is associated with serious events such as hypothermia, hypotension, resistant bradyarrhythmias, and even death. Laboratory findings may show elevated blood lactate, 5 mmol per liter, anion gap acidosis without ketonuria or ketonemia. Ketonemia means presence of ketone bodies in the blood, and ketonuria is defined as a presence of ketone in the urine. Attention everyone! It's important not to confuse ketoacidosis with lactic acidosis. Here I want to briefly show difference of these two medical conditions. Diabetic ketoacidosis is a life-threatening complication of diabetes, and lactic acidosis is a rare but serious side effect of metformin. Both diabetic ketoacidosis and lactic acidosis cause blood acidosis, but the causes are different. Ketones are detectable in the blood and urine of patients with diabetic ketoacidosis, whereas lactic acidosis occurs in the absence of ketones and results from pathological accumulation of lactate. Remember, in ketoacidosis, acidosis is caused by ketone accumulation, whereas in lactic acidosis, it results from lactate buildup. Lactic acidosis should be suspected in any patient on metformin with evidence of acidosis, but without ketoacidosis. Understanding the mechanisms behind metformin-associated lactic acidosis helps explain why it is rare but potentially life-threatening. Lactate is a waste product made by muscles and red blood cells which moves to liver cells for getting metabolized. The liver normally clears lactate by converting it into glucose through a process called gluconeogenesis. Metformin blocks gluconeogenesis process in liver by inhibiting mitochondrial energy production. This is a mechanism by which metformin reduces glucose production in the liver. When the liver can't convert lactate to glucose, lactate accumulates in blood. High lactate lowers blood pH and causes lactic acidosis, a rare but serious side effect of metformin. The timing of lactic acidosis is unpredictable, so vigilance is required throughout therapy. Lactic acidosis can occur at any time during treatment, from initiation to long-term use. Certain patient conditions and exposures increase the likelihood of developing metformin-associated lactic acidosis, which include kidney impairment, hepatic impairment, reduced tissue perfusion, for example, unstable heart failure. Concomitant use of drugs that impair kidney function, or increase serum concentration of metformin. For example, ranolazine and cimetidine can increase serum concentration of metformin. Concomitant use of metformin and iodinated contrast agents can increase risk of kidney impairment, which further can increase risk of lactic acidosis. Other risk factors include age greater than or equal to 65 years, surgery or procedures causing volume depletion, hypotension, or kidney impairment, hypoxic states, for example acute heart failure, myocardial infarction, sepsis, shock, and excessive alcohol intake. Finally, long-term use of metformin has been associated with reversible vitamin B12 deficiency, which can subsequently lead to fatigue and weakness due to reduced red blood cell production, megaloblastic anemia. Other symptoms of metformin-induced vitamin B12 deficiency include peripheral neuropathy such as numbness, tingling, or burning hand or feet. Cognitive changes like poor concentration or memory difficulties, and glossitis or mouth sores, red tongue or angular cheilitis. Vitamin B12 deficiency typically has a delayed onset and occurs after chronic metformin use. Several factors increase the risk of developing B12 deficiency in patients on long-term metformin. These risk factors include long-term duration of therapy, higher doses of metformin, for example greater than 1,000 mg per day, inadequate vitamin B12 stores, poor underlying nutrition, or impaired calcium absorption, and older age, greater than 65 years. Now that I've covered the 4 clinically significant long-term side effects of metformin, here are some practical take-home points for both patients and healthcare professionals. Clinical points for patients: 1. Take metformin with full stomach to reduce gastrointestinal side effects. 2. Report persistent gastrointestinal symptoms and notify your healthcare provider if nausea or abdominal discomfort persists beyond a few weeks. 3. Monitor for unusual fatigue, numbness, or tingling. These could indicate vitamin B12 deficiency. Periodic B12 testing is recommended for long-term users, especially if taking greater than 1,000 mg per day or over 5 years. 4. Stay hydrated and avoid alcohol excess to reduce the risk of lactic acidosis and kidney-related complications. 5. Follow dosing instructions carefully, avoid increasing dose without your healthcare advice, use extended-release formulations if advised to minimize GI intolerance. 6. Report any symptoms suggestive of lactic acidosis, such as unexplained malaise, myalgia, or shortness of breath. Seek medical attention promptly if any of these symptoms present. Practical points for healthcare professionals. 1. Assess baseline laboratory parameters and risk factors such as renal function, liver function, age, comorbidities, and concurrent medications before initiating metformin. 2. Monitor following laboratory parameters periodically, kidney function tests such as serum creatinine and estimated glomerular filtration rate. Liver function tests, AST, ALT in at-risk patients. Serum vitamin B12 levels, especially in elderly or patients who are receiving high-dose metformin for long-term therapy. 3. Dose titration, start with low doses and titrate gradually, and consider extended-release formulations to reduce gastrointestinal intolerance. 4. Identify and manage risk factors for lactic acidosis. Avoid metformin in acute hypoxic states, severe kidney impairment, or acute illness, and advise caution around contrast studies and surgery. 5. Educate patients proactively. Explain early warning signs of gastrointestinal intolerance, lactic acidosis, and B12 deficiency, so patients report symptoms promptly. 6. Consider supplementation, provide vitamin B12 supplementation if deficiency develops or risk is high. By recognizing, monitoring, and managing these side effects proactively, both patients and clinicians can ensure metformin therapy remains safe and effective over the long term. Thank you for watching. If you found this useful, consider subscribing to my channel for more clinical updates and practical tips.